Samantha said we were going to get tired looking at her this morning, so she's back up again now. And Samantha is going to just present what this first session was about. This is the first set of findings which really relate and focus on the prevalence of life-limiting conditions amongst children. So thanks a million, Samantha.
So, how many children in Ireland have life-limiting condition? That's kind of the first stage of our analysis. And it is an important first step in counting how many children might need palliative care. So just to clarify some definitions at the start, when we talk about life-limiting conditions in this work, we're including conditions that are life-threatening, where curative treatment may be feasible but can fail, for example, a cancer, and life-limiting conditions where there's no reasonable hope of cure. Now, I'm not a clinician, so if you want specific examples, there are several doctors and nurses in the room who can do all of that. So I want, first of all, to just take us back to what exactly we're trying to get at here, because, you know, it's a piece of a puzzle. Our ultimate goal is how many children need specialist palliative care in a country. So first of all, you need to define, sorry, I'm a researcher, you need to define what you mean by need, because you're working at a population level. This is a little bit different to when you're, you know, referring a patient in a clinical setting. And how is need quantified? So we did all that, don't worry, I'm not going through that today. We did a literature review where we examined, well, how is need for palliative care defined in the literature? How is it quantified? And one of the infographics at the back on the table kind of gives a summary of the project, but also just our kind of key findings from this literature review. So the first thing to keep in mind is we're working at a population level. So when you're making a decision in a clinical setting of who needs palliative care, you have referral criteria, and you assess all of the information you have about that child and their family. And you take all of that into account, and then you make your decision. But we're at a population planning level. We have access to national level data sets that may have some information on children. Particularly, you'd have diagnoses, you would have age and sex, but you have very little else. And we need to have a definition of need for children's palliative care that we can extract from national level data set. So we are working at a different level. So the definition necessarily is a little bit refined. So there is no universal definition of population level palliative care need in the literature. However, there is consensus that when you're defining need at a population level, you need information on diagnosis, but also you need to complement that or supplement that with information on their complexity of their care needs. So typically, there's a lot of studies there are a growing number of studies that are focusing on, you know, the number of children with a specific diagnosis. So a list of life-limiting conditions, how many children have those conditions. There is a growing literature on trying to identify how do we capture complexity, and we've done a nice piece of work on that in our own project. So you supplement the diagnostic information with the complexity information. Then you combine those two and you may get a greater sense of how many children with a life-limiting condition might actually need specialist palliative care in a country. You also need to consider, of course, that there will be children who don't have a specific diagnosis. They may have a combination of factors that together will pose a threat to their life, but, you know, no specific diagnosis. And there will be some of those children as well. And that's another step in analysis where you try and get a handle on those. And then if you focus, say, today we're focusing on prevalence that's based on hospital data. There may be children who are not specifically in a hospital in a given year. You also need to consider those. So having told you what goes into identifying how many children need specialist palliative care, you might be a little bit disappointed that what we're presenting on today is just this pink bubble. But it is a really important first step. I'm presenting the rest just to show you that it's not a one-step-fits-all. This is a complicated step in order to get what you're actually getting at, but we have made a huge progress in the work we're presenting today. So, some of you will think, but we already have estimates of the number of children with a life-limiting condition in Ireland. And yes, we do. And they are in our national policy that was developed in 2009 using data from 2002. This used estimates of prevalence from the UK and applied it to Irish population data. And then in 2015, we had an evaluation of our policy, and again, using estimates of prevalence from the UK, applying them to Irish population data, then we came up with an estimate of just under 4,000 children. But these are based on UK prevalence. And then more recently in the BWE report, again using UK prevalence. So can we do better than that? Can we look at Irish data and come up with some estimates? So we have come up with some estimates today. Obviously, I'm a conservative kind of person, so I need 3 estimates, not just one, because this is an estimation process. We can't just land on one particular number. We have to have a reasonable range. So in terms of the methods, prevalence is typically measured by, you have the number of children with a life-limiting condition and you divide it by the population and you can express it per 10,000 population. We are following in this analysis, we are following the work that was developed by Lorna Fraser, aka the lady in the front row who you'll be hearing from shortly. So in this what we're calling now the standard analysis, the inclusion criteria for the number of children with a life-limiting condition would be any child who has a hospital admission in a given year of analysis and who has a life-limiting condition that was either identified in that hospital admission or in a previous year. Because in the UK, you have a unique health identifier and you are able to track individuals from one year to the next. In Ireland, we have the hospital inpatient inquiry data set, which is the EIIHPC data set, where we can count hospital discharges. So if a child is in hospital maybe multiple times during that year, we can only count the number of discharges. We don't know how many children. So in any given year, we can count the number of discharges with a life-limiting condition, but we don't know how many children are behind those numbers. So we need to estimate that number, and we do that using 3 alternative estimation scenarios. We include anyone who is resident in Ireland. In other words, we're just excluding those who are on holiday visiting. As I said, we focus on the age group 0 to 19. And for our kind of benchmark year, we're looking at the year 2019. And obviously for our denominator, we're using CSO data for population. We go a little bit further because we know already that we're likely to be undercounting the number of patients in hospital with a life-limiting condition. And this again harps back to the lack of a unique health identifier. So some patients may be in hospital, but their life-limiting condition may, for whatever reason, may not be recorded in that specific admission. So just to give it a bit of a comparison, this is just an illustration. If patient A is in hospital in 2014 and their life-limiting condition is recorded, in Irish analysis, we can count that. In UK analysis, they can count that. But if that patient comes back again in 2015, the same patient with a unique health identifier, you're able to identify that. In the UK, we can count that patient. But if that patient in Ireland is in hospital again in 2015, and for whatever reason their condition, their life-limiting condition was not recorded, we can't count that. So we know we're missing some children. So we are fortunate in that there are estimates from the UK that kind of include and exclude those additional hospital admissions, and we can look at the differences between those 2 estimates and we can apply a sort of a correction adjustment. So getting on to estimating our number of patients. So we're using the information from 2019, and this is just to illustrate how we come up with our estimated number of patients in the age group 0 to 19 with a life-limiting condition in hospitals in Ireland. So there were just over 7,300 discharges with a life-limiting condition in 2019 in that age group. So for our first estimator, we want to rule out double counting that comes from transfers to other hospitals. So in Ireland, if you're, say, admitted to Limerick Regional Hospital and then maybe need to be transferred to a CHI hospital, that's the same episode of care, but in EIIHPC, it's counted as 2 discharges. So we exclude any discharges out to other hospitals, just to kind of control for that double counting. So under E2 then, we take that estimate from E1, controlling for those transfers out, and then we make a further adjustment for any child that may have had a multiple admission during that year. And we don't just pluck that out of the air. We have some data from adult discharges where it's estimated that about 12% of adult discharges are multiple discharges. So we take 12% and we estimate that there may be about 2 admissions per year using available case study evidence. And so that brings our estimate down to about 5,000, just under 6,000 patients. In our E3 then, just to give a kind of a low, medium and high estimate, we take our E1 estimate and we make another adjustment for multiple admissions, this time using evidence from the literature. So it's in the small literature that's available, that one of the major factors in multiple admissions amongst children is having 2 or more chronic conditions. So for any of our discharges that had 2 or more chronic conditions, we estimated that they had about 2 admissions per year. So that's our 3 estimates of patients, and then what we do is we put those over the population and we get our prevalence estimates. So we are focusing on the E2 estimate principally because it just sits in the middle and it's a reasonable place to sit. So here we have our E2 baseline, and there we have the adjusted, where we took into account any sources of undercounting in the data. And these are the headline figures that you've seen in our project outputs that are on the table at the back, and now hopefully up online. That there are just under 6,000 to 8,000 children with a lifelong condition in Ireland based on data in 2019. Which is a prevalence of just under 45 per 10,000, up to nearly 60 per 10,000. In terms of the variation by age, prevalence was highest among the infants under 1 year. It's also higher amongst males, and it's also highest for neoplasms and congenital or chromosomal conditions. There is some variation across the country, but I'm going to go into this a bit more later in the day. So you do need to take into account when you're planning a service some variations in prevalence across the country. But there is a slight warning here in that the dark colours look like they might stand out. When you digest it into the actual numbers of children that vary across the different regions, they're not huge numbers. So just a bit of an interpretation warning there. It's not as different as it may look. When we compare with similar income countries that have done the same analysis using similar methods, these are our 3 Irish estimates that are broken down by age, and then we just put in the blue lines there which show estimates from England and Wales. So the age patterns are very similar across the different countries. There's some slight unusual pattern there happening at Wales. That's more to do with differences in age groupings than any real differences. So what does this mean for policymakers and providers? First of all, I think it's fairly clear that the national policy revision is coming at a very good time. We have an estimate that is very much below what we are currently estimating to be the number of children with a life-limiting condition in Ireland. So at the very least, the national children's palliative care policy needs to be updated. Even if we were to take our lowest estimate of prevalence of 34.8 per 10,000, that's still much higher than the policy and still much higher than the estimate that was developed in the policy evaluation in 2015. The second thing to note is because the prevalence is highest in the under the 1 age group, it just strengthens the need for supporting the development of perinatal and neonatal palliative care amongst the neonatal and maternity units across the country, and supporting the development of the perinatal palliative care pathway. And the third thing to note is we've shown the prevalence side and the variation by regions. It is very important to address where the supply of specialist palliative care is, and to take into account variations in prevalence across the country when you're planning the supply. I will go into that a bit more later in the day when you see me again. So what more do we need to know? Again, I'll be raising that later when you see me again. Thank you.